much. I really appreciate the opportunity to join you, even if at a distance. So I am going to change gears a little bit and look at the other end of the infection question, at least from a clinician's point of view, and the effect of antibiotics exposure on obesity. I'm going to focus primarily on a small set of studies with references to other similar work that's been done, but to give us an opportunity to look at the methodology and some of the strengths and limitations of it. All right, next slide, please. I'd like to start by acknowledging the fact that this kind of population-level research really represents a collaboration among large numbers of both investigators and, perhaps more importantly, patients. Right? In the era of electronic health records and health information exchanges, we have a new kind of substrate to look at the way health is played out in sort of the delivery of normal clinical care, and excuse me, that incorporates the work of lots of unnamed collaborators seeing patients every day, lots of patients who have entrusted us with their data, and I want to sort of right up front acknowledge the contributions that they make. Next slide, please. Also, by way of framing for the discussion, I have no financial conflicts of interest to disclose, but I do want to make clear up front that I work at the Children's Hospital of Philadelphia. Some of the work we're going to talk about this morning was funded under the auspices of the Healthy Weight program at CHOP, and that program has independently received funding from the American Beverage Association. I think sort of transparency is good up front. I will also mention, as is stock and trade for a pediatrician, that along the way I am surely going to mention some off-label uses of medications, since relatively few pediatric indications exist. All right, the next slide, please. The last bit of framing that I want to do is I couldn't let the opportunity at an IOM roundtable pass to note the context in which these studies were done. So I'm going to describe population health done in the context of routine care following a model that has been largely expounded by the IOM of the learning healthcare system. And next slide, please. In particular, to pick up on the acronyms of the day, part of what I want to do is use this as a demonstration of the value of a learning health system for health services and comparative effectiveness research. In particular, these studies become possible because of the scale and the connectedness of the information that are available about large populations of patients, enabling so-called secondary use. Next slide, please. So on to the studies in question. I want, excuse me, to start by describing two studies in the context of the PEDSNET collaborative network. So this is a data-sharing partnership of 8 large children's hospitals who are committed to the development of learning health systems in pediatric clinical care. And we have looked at obesity as one of the more pressing public health problems among children, both as a proof of concept and in order to develop new knowledge in this area. So the first study I want to describe is by way of technical background for looking at the role of antibiotics, and it's what we would call our obesity pilot. So this is a study conducted in 2010-2011 by 6 of these 8 hospitals, looking at a 2-year block of outpatient data and asking descriptive questions around our ability to identify and measure obesity in this population of around 500,000 children. In particular, we wanted to address the question of the suitability of routine clinical data for looking at questions regarding obesity and the treatment of obesity. So we focused on clinical data regarding body mass index. This is actually a place where we have a bit of a leg up in pediatrics because measuring heights, weights, and body mass indices are routine parts of our practice, if for no other reason than they're necessary to dose medications. And so there's a relatively rich source of data. And you can see, for instance, that we have the advantage of having about 6,000 BMI measurements in this cohort per month of age, in contrast to between 17 and 35 in the NHANES benchmark data set, so that we have a lot of opportunity to offset noise in the data by looking at the behavior of the data in aggregate. And if you move to the next slide, you'll in fact see that what I'm showing you here is mean BMI over growth. This is for populations of girls, and the red line you see is the data that is derived from routine clinical measurements and electronic health records. The data in the green are the weighted sampling results from NHANES, and we were pleased to note that we track NHANES growth curves fairly closely. As expected, we have much less hysteresis, particularly at older ages where our sample sizes are larger. But this, and if you look at the next slide as well, please, our estimates of prevalence of obesity in the population match the NHANES data very closely, and so give us some confidence that it's reasonable to use these types of data to measure obesity as an outcome in populations of children receiving both well-child and acute care. Similarly, and given the time constraints, I won't go into validation. Our window into drug utilization is primarily via prescription data, so orders written by physicians and nurse practitioners seeing patients to a lesser extent dispense medications. An audience at this level of sophistication will recognize immediately that there are some gaps there, including out-of-network care and the potential mismatch between prescription data and the medications that patients actually take. So we're going to have a particular set of systemic biases in the way we look at data, and I will advert to some other studies that have taken different approaches as a way to balance that out. The last thing I want to say about the use of obesity data is if you look at the way pediatricians, at least, diagnose obesity, and there's literature to suggest that this is not significantly different in adult practice, what we were able to demonstrate is, if you look at the left side of this figure, all physicians taken together recognized or at least documented a diagnosis of obesity in approximately 18% of patients who, by BMI, actually met criteria for obesity. And outside the setting of dedicated weight management clinics, no one is documenting this more than about a third of the time. In particular, what this highlights is the difficulty of doing this kind of work using administrative data, such as claims or state-level data sets, because we're going to miss 80% of our outcomes due to lack of diagnostic coding. All right, moving on to our look at the potential effects of antibiotics. I think we, like many others, are interested in the potential impact of the microbiome on development and progression of obesity in children and over the long term in adults. Other studies have shown sort of strongly suggestive data that decreased diversity of gut microbes, and in particular shift to a small number of higher risk species, are associated with higher prevalence of obesity, and that environmental factors which perturb the GI microenvironment and contribute to overgrowth of specific species can be associated with greater or lesser degrees of obesity. The mechanisms for this are unclear, right? Possibilities include direct effect by gut microflora on energy metabolism, both outside the host and due to changes in the way the host absorbs or metabolizes calories. Alterations in the immune response, and in particular generation of chronic low-level inflammatory stimuli, which may predispose to obesity, due to factors such as increased endogenous steroid release and insulin resistance, and also changes in an individual's food-seeking or calorie consumption behavior due to differences in the digestive pattern to which the microflora contribute. Next slide, please. In particular, we're interested in the possibility that infancy and early toddlerhood is potentially a critical period for establishment and stabilization of the gut microbiome. Again, limited data are available, but studies have shown a tendency in older children and adults for, if you will, a sort of microbiomic homeostasis, a tendency to return back to the original composition of the gut microbiome following exogenous stimuli or exogenous influences. So we wanted to go back to the spring at the head of the stream. Right? And as we all know, the microbiome is established really from the moment of delivery onward. There is clearly a parental effect, and studies looking at composition of gut flora have shown that there are components of the microbiome in children that appear to be, for lack of a better word, inherited, at least sort of more concordant between twins and between parent-child triads. And there seem to be others that are more responsive to the local environment. The details of this plasticity are not well understood, and in particular the role of environmental stimuli are unclear. There are some hints. As I mentioned, there are associations with decreases in diversity, in particular shifts and increased obesity. There are also studies that have demonstrated that change in the lipid composition of the diet is associated with some changes in the gut microbiome, and that one can artificially induce a change in gut microflora by gut microbial or microbiomic transplants, so-called fecal transplants. Although, interestingly, those changes, again, tend over time to return to the sort of individual's prior or pre-transplant baseline, and it's not clear how much of that is a homeostatic effect autonomous to the microbiome and how much of that is the ongoing effect of outside environmental factors which the transplant did not affect. Finally, if you look at animal models, there have been some very interesting studies showing that not only changes in diet for mice influence obesity, but giving antibiotics to pregnant mice around the time of birth generates a higher proportion of obese pups, and those pups are more likely to grow into obese adults. Next slide, please. So we wanted to ask specifically, how might antibiotics fit into this picture? Given that early childhood might be a particularly critical period for establishment of the microbiome, we were curious whether differential exposure to antibiotics, which we expect to at least transiently change the microbial flora in the gut, and in particular the microbial bacterial diversity, might have long-term effects on risk of obesity. All right, I do want to look at a couple of other studies, so if we could move to the next slide, please, before I go in detail through our methodology, that kind of lays some groundwork in this area. So there's a set of results from a birth cohort in the UK that followed just over 10,000 children from birth through, I believe, 9 years of age. This cohort was largely sort of upper middle class, as noted, 93% Caucasian, and the cohort was followed for environmental exposures primarily through surveys and parental recall. There were direct measurements of growth parameters, and so obesity was able to be estimated directly at several time points up through 7 years of age. So a retrospective review of these data found an increase in toddler obesity if antibiotics were taken in the first 6 months after birth, but not subsequently. And then interestingly, found a higher BMI, although not consistently over the threshold for obesity in primary school age children associated with antibiotics taken late in the second year after birth. Right, so there appears to be some connection, although the specificity of the effect is unclear. All right, next slide, please. Similarly, work done in a Danish cohort following up close to 30,000 children, so a substantial plurality of births during the studied period in Denmark, again looked at parental recall as an index of antibiotic usage and growth by way of questionnaire administered at 7 years of age. And again, what these folks found is that in primary school age children, if antibiotics were taken in infancy, there was an increased risk of overweight, but interestingly, this only applied in the absence of maternal overweight. Right? So this study found, and this is a finding thus far unique to this cohort, that the exposure to antibiotics in infancy actually produced a decrease in overweight risks if a child was born to an overweight mother. So, again, some interesting suggestions that perturbation of the microbiome that one inherits in part from one's parents may affect long-term risk of obesity. Similar results have been published recently from a Canadian retrospective review of provincial-level birth and utilization records. And interestingly, that group found the association between infant antibiotic exposure and later obesity risk only in boys. So, the landscape makes clear that there is a repeatable correlation found, although causality is always difficult to infer from these studies, but that whatever the mechanism behind the correlation is, it's not going to be simple and straightforward. All right, next slide, please. So, as I mentioned, most of these studies are using parental recall for information about exposure to antibiotics and have cross-sectional measurement of growth parameters at discrete time points. They are able, because of the birth cohort design and the survey design, to get very good information about covariates, including lifestyle and environmental factors, but they're necessarily limited in their ability to look at the longitudinality and the degree of antibiotic exposure and the growth trajectories of kids. So as a complement to that design, what we did was conducted a study within one large healthcare system in the Mid-Atlantic U.S., looking back over about a 15-year window. We have the advantage of having a well-entrenched electronic health record with both prescribing and growth measurement data that looks back, in the best case, about 15 years. For the majority of our patients, about 8 or 9 years. And so we're able to assemble a longitudinal cohort. Excuse me. We didn't, because we're working with a pediatric network, require in-network birth, but we did require initiation of primary care within the first year after birth, and then longitudinal follow-up at least past the third birthday. We collected data on antibiotic exposure in the first 2 years, so 0 to 23 months of age, based on prescription records seen in the EHR. And in analyzing these results, we categorized antibiotics into two broad classes, which I'll call narrow spectrum and broad spectrum. That I understand is going to raise the blood pressure of any microbiologist in the room, and we fully admit that those are very broad brushes with which to paint a complex class of medications. Our intent here was in part to represent the antimicrobial spectrum of these drugs, but also in part to reflect recommended usage for common infections in childhood. And we're able from these health records to demonstrate that the vast majority of antibiotic prescriptions are for common childhood infections such as ear infections or pneumonias or sinus infections, that sort of thing. And there are established and evidence-based guidelines that have been available for the better part of a decade in pediatrics that demonstrate the value of using sort of minimal spectrum antibiotics in the majority of these cases, often observed in the breech, of course. We collected data on body mass index for these children starting at 24 months of age over the following 3 years, and we computed Z-scores based on the NHANES 2000 norms and scored obesity at 95th percentile or higher, and overweight at 85th percentile or higher. Next slide, please. So what this yielded was a cohort of 65,000 children, excuse me, reflecting the structure of the network. A third of them lived in urban neighborhoods in and around Philadelphia, and the remaining 2/3 in suburban neighborhoods. Nearly half of them identified as belonging to some racial or ethnic minority, and about approximately 40% at some point in the study period were covered by a public insurance provider. I mentioned that we started assessing the outcome at 3 years of age and continued through 5 years for the time-dependent models. I'll note that 61% of the patients had a full 5 years of follow-up for assessment. All right, next slide, please. some preliminary observations to note from the study. First of all, we found, unfortunately not to our great surprise, that use of antibiotics is very common in early childhood. So what you're looking at here are degrees or times of initial exposure to antibiotics. Right? And so reading from left to right, you see successively greater ages of first exposure. The sort of gray bar at the right shows you the fraction of children who made it to age 2 without any antibiotic exposure, and you can see that roughly 2/3 of children had some antibiotics prescribed to them prior to their 2nd birthday. Exposures are typically highest near the 1st birthday, and that corresponds to prevalence of common childhood infections. Next slide. The other thing to note about the exposures are that excuse me, for many kids, this is not a single event in their childhood. Right? Again, if you look at different classes of antibiotics, a substantial number of these kids are seeing multiple exposures. We will make use of that in our analyses later. Excuse me. And again, it's worth noting that these are typically for treatment of common childhood infections. So the children repeatedly exposed are not typically children with chronic medical conditions whom we would expect to be in a different physiologic or growth trajectory than the majority of children. All right, quickly summarizing then, the multivariate analysis looking at a number of covariates shows association between obesity in ages 2, 3, and 4-year-olds, so toddler-age children, and factors that have been demonstrated in a variety of other studies, right, including male sex. We see an effect for Hispanic ethnicity, but not for other race groups. That's been variable across different studies. We see an association with public insurance coverage as a very crude estimator of socioeconomic status. Interestingly, we don't see that map into urban versus suburban location of practice, despite differences in median incomes across those environments. As has been demonstrated before, we see a strong association between obesity and a diagnosis of asthma. Some of that we expect is accounted for by steroid usage, which is an independent predictor of a moderate effect, even in multivariate analysis. Some of that also probably has to do with changes in activity, but I suspect some of it also has to do with the inflammatory nature of the disease. Next slide, please. In particular, when we look at antibiotic exposures, there are a couple of interesting findings here. Right? The first, what we're seeing here is a hazard ratio for obesity in toddler years based on antibiotic exposure during infancy. First, what we see is a trend toward increasing risk of obesity with increasing exposure to antibiotics. In particular, if you look at the upper 2 blocks, so the gray block at the top is all antibiotics, the red block in the middle are the more broad spectrum drugs, the green block at the bottom are the more narrow spectrum drugs. So as we see increasing exposure, we see increasing risk. That's particularly marked in the broad spectrum group. At the highest levels of exposure, you can see that the confidence intervals widen sharply and the median comes down because we do see some contribution we expect from chronically ill children. Right. The other interesting finding for us is that while there is a slight increase in hazard ratio, there is neither this trend nor a significant association in children exposed to narrow spectrum antibiotics only, even at higher levels of exposure. Right, next slide, please. So this leads us to 2 operating conclusions. The first is that antibiotics early in childhood, in particular in infancy, are associated in our view of children's healthcare utilization with a small but persistent increase in obesity, distant from the exposure to antibiotics. So, whatever is mediating this association, if the antibiotics are causal, it can't be explained by temporary deflections in growth trajectory or perturbations in the gut microbiome associated with the time of exposure. Important for us as well, the majority of this effect appears to be associated with broader spectrum antibiotics. And this is a significant clinical point because, as I noted before, there's substantial evidence that narrower spectrum drugs are adequate therapy for most of the kinds of infections that are being treated in this population. And so the decision to use broader spectrum antibiotics will often hinge on physician preference or convenience of dosing or other non-antimicrobial parameters, and it's important to underscore that, that there may be unintended effects at work here. We're certainly interested in the mechanism here, and in particular in the possibility that there are lasting changes in the composition of the microbiome that persist out of infancy. And we have another study running at the moment that's actually looking at direct effects on GI microbial or bacterial composition subsequent to antibiotic exposures that we hope will help us get at that mechanism. Next slide, please. Again, in the interest of transparency, I need to be very upfront about some of the caveats that follow from this kind of a study design. I've talked about some of the biases that arise from it's being anchored in health care or health system data. In particular, while we have very granular information on both diagnoses, infectious and otherwise, and on antibiotic prescriptions, we have much less clear capture of longitudinal factors affecting the family or family structure and of lifestyle and dietary factors. This gets to be particularly important because the effect sizes we're seeing here are relatively small. We're talking about 10 to 20% deflections in risk. And so it's going to be critical going forward to be able to marry this sort of a study design with the sorts of designs that were effective in the birth cohorts I described that provided detailed insight into lifestyle factors without the kind of detail that we have available in health systems. Right? And then finally, because this is all a regional study, I also need to advert to the potential for geographic or local practice effects. Next slide, please. Having said that, I think the points I'd like to leave you with are, I think it's clear to everyone here that there's unlikely to be a single so-called silver bullet that will dramatically increase either prevalence or risk for obesity in children or adults. And effectively addressing this healthcare problem is going to require a large number of incremental changes, some of which will be useful to only subsets of patients. In particular, our stance here is that careful use of antibiotics, not necessarily non-use of antibiotics, but careful use tailored to appropriate indications and tailored to appropriate antimicrobial spectrum may actually have an impact at the population level on risk of obesity and merits consideration both from a research perspective in terms of insight into establishment and maintenance of the gut microbiome, and from a health services perspective in terms of determining sort of weight-friendly or obesity-friendly healthcare practices. All right, I'll stop there. Thank you very much for your time and for listening.
Thank you so much, Dr. Bailey, for a wonderful presentation. We have time for perhaps one or two questions for clarification, if there are any. We have one question, and then...
Thank you, Linda Birnbaum. One of the questions I have is obviously antibiotics are targeting bacteria, but what about some of the antiviral medications? Is that beginning to be used more in a young pediatric practice, the Tamiflu, et cetera, or those kinds of things? And would that be interesting to look at? Obviously, that might, in fact, the virome as opposed to what we normally call the bacterial microbiome.
No, point well taken. I think oseltamivir is the most common drug we see in practice. We do see some usage of acyclovir as well. The prevalence was much lower than antibacterials, and so at least in the cohort we had available, we didn't think we would get the power to detect that, but I think that's an excellent point. The other thing that we observe is usage of systemic antifungals in children, both for mucocutaneous infections like thrush in infancy, and for things like tinea cutis or other sort of superficial fungal infections. And no one, to my knowledge, has assessed their impact on gut microflora as well.
Thank you for that. We have one more question, and then.
Hi, Sheila, South United University of Washington. That was a great presentation. I just had a question. You had talked about a mouse experiment where they gave antibiotics in the perinatal period and then observed obesity later. And I'm wondering if anybody has looked at antibiotics being given in human perinatal period and looked at the growth trajectories from the electronic medical record, because that seems like with the health data that we have, it would be an easy thing to do in an HMO kind of setting.
So I would love to see that. It was a study that we weren't able to do because we don't have the medical records of mothers available to us, but I agree with you, in the right kind of studying, either an integrated health system that's following families, or when we get through another turn or two of the crank on health information exchange, the ability to integrate that data over a geographic region is going to be highly valuable, partly because it will give us information about vertical antibiotic exposure, and partly because it will give us information about covariates like maternal weight gain and maternal obesity.
Thank you. Thank you for that. Okay, I'm now going to invite Aisha Erkin-Kakmak to come forward and begin her presentation.